The following video is a presentation by the Departments of Anesthesiology and Medicine of the Mount Sinai Medical Center. Its purpose is to enhance patient safety by educating practitioners in strict aseptic technique and ultrasonic guidance of jugular venous cannulation by the Seldinger method. The use of strict aseptic technique is associated with a six-fold reduction in the risk of central line-associated bloodstream infections, also known as CLABs. These demonstrations were performed in an operating room, but the steps shown can be applied universally in all patient care settings where central lines are placed. The device inserted in this video is a 9 French vessel introducer, but the principles of central venous cannulation are mainly similar for other large bore catheters, such as 7 French triple lumen catheters. The patient is positioned supine with the head slightly below the feet. The head is turned away from the side to be cannulated, taking care in patients with cervical spine disease. The skin is then widely disinfected with chlorhexidine, which is preferred over povidone iodine because of its association with decreased incidence of CLABs. Note that the prep area is wide. It should be centered over the site of needle insertion, but should extend above the mandible, below the clavicle, across the midline of the neck, and laterally to the acromion. Due to the wide area covered and absorption of the prep solution by the umbilical tape securing the endotracheal tube, a second prep applicator may be necessary. Allow the prep solution to fully dry. Aseptic technique requires the use of proper sterile barriers. The practitioner must don a cap to cover the hair, a mask to cover the mouth and nose, and a sterile surgical gown and gloves. Surgical hand hygiene is also required, beginning by removing all watches and jewelry from the arms and hands. Here we demonstrate the use of a scrubless hand prep solution, but a full surgical scrub is also acceptable. Make sure to dry hands with paper towel thoroughly before applying the solution, and then allow the solution to dry spontaneously. As we demonstrate here, proper self-gowning and gloving using closed glove method is imperative for strict aseptic technique. It is important to note that the gown and gloves should be laid out on a prep table or a mayo stand dedicated to this purpose. It is improper to use a contaminated surface such as a dirty linen hamper. Additionally, the gown should always be tied by an assistant to prevent contamination of the gown. The practitioner should then use the sleeves of his sterile gown to down his own gloves by the method demonstrated here. Anyone unfamiliar with this process should contact operating room staff. OR nurses and scrub techs are an excellent resource in this area. Next, the patient is draped. First, a fenestrated drape should be placed over the line insertion site. Do not drag the drape from a non-sterile area to the prep site. As it is an occlusive drape, the underside of the drape should make firm contact to the patient's skin. Second, a full-body drape completes the field. After the drape is opened onto the patient, a fenestration is created by tearing the drape directly over the insertion site. The use of a scalpel for this purpose is discouraged to avoid inadvertent injury to the patient beneath the drape. Safely cannulating the internal jugular vein without injury to surrounding structures is of paramount concern. The use of ultrasound identifies the internal jugular as well as its relationship to the nearby carotid artery. This prevents inadvertent arterial puncture as well as reduces the number of needle sticks required to successfully enter the vein. Non-sterile ultrasound probes must be placed into sterile sheaths. To ensure proper acoustic transmission across the plastic sheath, it is imperative that the sterile ultrasound gel coats both the inside and the outside of the sheath overlying the probe tip. The tip of the sheath must be smooth and all air bubbles removed before a sterile rubber band is placed to maintain tight contact between the probe and the sheath. Place any remaining ultrasound gel onto the sterile field. The exterior of the sheath is then dipped into the sterile gel and placed on the neck over the proposed insertion site perpendicular to the skin. This ultrasound view depicts a cross-section of both the internal jugular vein and the carotid artery. The internal jugular is typically lateral and is easily compressible. The carotid is generally pulsatile and incompressible. It is essential to identify both of these vessels to ensure that the target vessel is indeed the internal jugular vein, as well as to avoid arterial injury. Once the target vessel has been confirmed, visually inspect the insertion site to ensure that the external jugular vein does not overlie the site of catheter insertion or eventual suture sites. The proper insertion site and trajectory is based on triangulation of the ultrasound probe and the target vessel. Here the vein is 10 mm below the skin as seen on the depth finder of the ultrasound display. Therefore, the needle catheter assembly should be inserted 10 mm cephalad and in line with the probe at a 45-degree angle to the skin. After penetration of the dermis, continuous gentle aspiration is applied to the syringe as the needle is advanced. Note the indentation of the anterior surface of the vein as the needle approaches it. Because the vessels and needle are passing through the plane of the ultrasound probe, only a cross-sectional view of the needle is possible. Therefore, it is important to maintain a perpendicular orientation of the probe on the neck to visualize the needle tip as it enters the vein. Once the vein is entered, blood will easily return into the syringe. Advance an additional 2 mm to ensure that the plastic catheter tip also enters the vein. The needle and the syringe are withdrawn together while stabilizing the catheter. Take note that the catheter hub must always be occluded to prevent air entrainment, especially in spontaneously breathing patients. Place the needle and all other sharps back onto the instrument tray for safety. Attach the syringe to the catheter and aspirate gently. If the catheter tip is within the lumen of the vein, blood will easily return and the catheter can be advanced all the way to the hub. If the catheter does not advance, using the J-wire may be helpful. Venous placement must then be confirmed by manometry. Attach a length of sterile tubing to the catheter hub. Hold it below the neck and allow it to fill with blood. Then elevate the tubing, observing the fall of the column of blood to a level consistent with venous pressure. If the column does not fall freely, the catheter may be misplaced or kinked, or the tip may be occluded against the vessel wall. Alternative confirmation methods are pressure transduction, blood gas comparison with an arterial sample, or fluoroscopic visualization of the guide wire in the superior vena cava or right atrium. It is not acceptable to use the color of the blood to confirm venous placement. Remove the manometry tubing and advance the J-wire to a depth of 20 to 25 centimeters in an adult. Monitor the ECG at this time, as the wire may cause ectopy if it enters the right atrium or ventricle. If ectopy does occur, withdraw the wire a few centimeters and it should resolve spontaneously. Then remove the plastic catheter and straightening adapter. Next, to make a skin nick, the scalpel blade should be laid flat against the wire with the sharp edge directed laterally away from the carotid. Take care when inserting the blade that it maintains constant contact with the wire. This can be assured when there is tactile feedback of the metallic knife grating against the metallic wire. Advance the blade 2/3 of its length and return it to the tray. Application of gauze and gentle pressure to the wound will reduce blood loss. The introducer and dilator assembly are then placed over the wire. If necessary, withdraw the wire until it emerges from the top of the dilator. In the Seldinger technique, it is imperative that the operator never loses control of the wire. Advance the entire assembly along with the wire to a depth of about 1/3 the length of the dilator. If the wire moves easily and is not bent or kinked, it is confirmed that the dilator is following the wire's trajectory. Next, brace the wire and advance the dilator and introducer half the remaining length. Typically, 2 pops are felt as first the dilator, then the introducer penetrate the fascia of the neck and enter the vein. Again, confirm that the wire moves easily before bracing the dilator and advancing the introducer alone the remaining distance to the skin. Remove the dilator and wire together. An additional step in infection control can be the placement of an antiseptic dressing such as a chlorhexidine impregnated disc as seen here. Several commercially available alternatives are also acceptable. Finally, secure the central line. Several different designs exist and each should be secured according to manufacturer instructions, but there are a few general guidelines to note that apply regardless of central line type. First, taking large bites in the skin and avoiding excessive skin pressure by tying air knots will help prevent pressure necrosis at the suture sites. Second, for silk suture, as comes standard in most central line trays, 3 square knots are generally recommended for maximum security at each suture site. Finally, whenever passing a straight needle through an eyelet, always lead with the blunt end of the needle for operator safety. After effectively suturing the catheter into place, the area should be cleaned once again with chlorhexidine solution. After the solution is allowed to dry, a sterile dressing should be applied to the insertion site to minimize infection risk. To review, this video demonstrated several techniques that have been shown to maximize patient safety related to central venous catheterization. The proper use of skin preparation and sterile barriers has been associated with a 6-fold reduction in central line-associated bloodstream infections. Using real-time ultrasound guidance reduces the incidence of procedural complications such as arterial injury and pneumothorax. We recommend these procedures for increased patient safety.